Good afternoon, everyone. Today we'll continue our weekly activity with Dr. Zainab Al-Ayed. We're going to talk about the coronary artery bypass grafting. Our consultant from Dr. Babtain, Dr. Farouk Uwaida, we welcome him to joining us. So we'll start after a couple of minutes, inshallah. Dr. Zainab, please prepare your slide. Thank you. Dr. Zainab, تفضل, you can start.
Good afternoon, everybody. So, I'm Zainab Al-Ayed, an R5 resident from Untitled Chapter. Today I'll talk about myocardial revascularization. I'll be covering myocardial revascularization on and off pump with the hybrid procedures. These are my reference. So Pre-Operative Assessment is crucial in any surgical specialty, and it should focus on symptoms and signs of ischemia, congestive heart failure, and valvular heart disease. And should also have or check for any comorbid condition like CVAs, peripheral vascular diseases, malignancy, sternal radiation, or history of sternal radiation, COPD, diabetes, renal or hepatic insufficiency, the DVT prior or history of vein stripping. Medication also should be covered or asked for, especially the antiplatelets use and anticoagulation. Cardiac cath, echo, chest X-ray, ECG, and labs should be reviewed, and procedures with the risk and benefit should be explained to the patient and their close family. So bypass conduit will be covered with by Dr. Faisal Al-Ghamdi on next week, inshallah. Today, I'll just mention what are the conduits that can be used in CABG. Left internal mammary artery and saphenous vein graft are the most commonly used conduit. Right internal mammary and radial artery can be used in case of total arterial revascularization. There are some other arterial and venous conduit that has been used in the past, and nowadays are rarely used. On pump CABG, the procedure are done under general anesthesia with the central venous axis and radial arterial axis. TE may be helpful for identification of unsuspected intracardiac lesion or aortic atherosclerosis and for evaluating ventricular function at the end of the procedure. In case the patient have a poor ventricular function, a femoral arterial line can be inserted to facilitate later replacement of intra-aortic volume pump if needed. So the on-pump CABG is done by median sternotomy and standard median sternotomy with the arterial line in the ascending aorta and venous drainage through the right atrium. Bicaval cannulation can be used in case of concomitant procedure like mitral or other valvular or tricuspid. Myocardial preservation can be achieved by cold blood cardioplegia that infused through antegrade or retrograde in case of severe ostial occlusion that will prevent uniform cooling of the myocardium and the distribution of the cardioplegia will be suboptimal. Additional cardioplegic solution can be infused directly into the vein graft after the distal anastomosis is completed. Cooling the patient to 34 Celsius with the topical cooling of the heart with a cold or ice saline can supplement the myocardial protection. Arteriotomy site should be chosen proximal enough to offer the largest size of the coronary artery target, but distal enough to avoid any the area of obstructing lesion, and it should be avoided at the bifurcation site. Here, as shown in the pictures, a stroker is used to expose the coronary artery, and then poker blade is used to inside the anterior wall of the coronary arteries. And then extending the incision by pot scissor, proximally and distally, to match the conduit diameter, and it should be at least 1.5 times the luminal diameter of the distal coronary artery. To calibrate the coronary artery, a coronary probe can be used but careful and not to force it, or not to use. Also, don't use any too big size that will cause intimal injury. And careful not to perform arteriotomy as an oblique incision. It should be a midline on the coronaries, because if you did an oblique incision and if you try to correct it, it will create a flap which will distort, either if it's oblique or if you create a flap, it will distort the anastomosis at the heel or the toe. Injury to the posterior wall can happen, so to avoid that, the blade should be inserted at an angle of 45 degrees. If injury happened to the posterior wall and as a suture, it should be approximated with fine HO-proline and tied outside the vessels. If you have intramyocardial course of coronary artery, you should follow the artery into the muscles, and the myocardial bridge over the artery must be divided with a great caution. The intramyocardial segment rarely have disease, or the division of the myocardial bridge must be limited to the extent that's needed to perform satisfactory anastomosis. And to cauterize the edge of the muscle bridge, low current electrocautery should be used. This is a video. Will show the coronary arteriotomy, how it's done.
Coronary arteriotomy is primarily utilized for coronary artery bypass grafting, or less frequently, coronary endarterectomy. Coronary artery bypass grafting remains one of the most commonly performed surgeries in the United States, making mastery of this ubiquitous technique essential for a cardiothoracic surgeon. The site of the arteriotomy is primarily dictated by the location of the stenotic or occlusive lesion, which can be determined by preoperative imaging in conjunction with manual intraoperative palpation. In general, ideal arteriotomy sites are distal to the stenosis or occlusion, epicardial, and devoid of tortuosity or gross disease. The circumference and geometry of the arteriotomy should correspond to bypass conduit measurements. For example, small and large conduit lumens necessitate small and large arteriotomies, respectively. The bypass conduit should be distended during these measurements to simulate in vivo dimensions. A fresh number 15 coronary scalpel blade should be utilized for each separate arteriotomy. Prior to creation of the arteriotomy, the vessel should be visible without being obscured by overlying tissue. The scalpel blade is positioned at a 45-degree angle to the tangent of the vessel circumference, and the incision is made longitudinally at the midline of the vessel. The incision is then extended proximally and distally to accommodate the bypass conduit. Cardiac movement is minimized during all incisions. Though complications are rare during coronary arteriotomy, care must be taken to avoid coronary artery dissection, as well as perforation of the posterior vessel wall. Coronary probes can be used to confirm entrance into the vessel lumen. This first video clip illustrates an arteriotomy at the Ramus Intermedius, a branch of the left main coronary artery. External inspection reveals both visible epicardial and deeper intramyocardial aspects of the vessel's course. Although superficial translucent epicardial vessels are the preferred sites for arteriotomies, careful division of the overlying epicardial and myocardial tissues can permit safe utilization of intramyocardial vessels. Gentle, sweeping transverse movements with the scalpel blade facilitate further displacement of overlying tissue. Bilateral retraction perpendicular to the length of the vessel can provide helpful countertension for the incision. The epicardium and underlying myocardial tissues are carefully divided, exposing the partially intramyocardial coronary artery. A longitudinal incision is made along the midline of the vessel, with the scalpel blade positioned at 45 degrees to the tangent of the vessel circumference. The arteriotomy is then extended proximally and distally to match the circumference and geometry of the conduit lumen. This second video clip demonstrates a more superficial epicardial diagonal branch of the left anterior descending artery. Again, using a fresh number 15 coronary scalpel blade with adequate retraction and countertension, a longitudinal incision is created along the length of the vessel. The arteriotomy is extended proximally and distally to match the circumference and geometry of the bypass conduit, which can be visualized in the background. When extending the length of the arteriotomy, the tips of the scissor blades should be used to optimize control.
So for positioning the heart to expose the coronary artery, the anterior surface of the heart can be exposed with the lap soaked in iced cold saline and placed into the pericardium behind the empty the heart. This will bring up the LAD diagonal, and with minor adjustment, Ramus intermediate also can be viewed in such position. For the right coronary artery, it's usually a large vessel and it's covered by epicardial fat in the right AV groove. The distal branches, posterior lateral, and the PDA tend to be more superficial as its course toward the toward the apex of the heart. To expose the RCA, the table can be elevated with the slight Rendenberg position, and the acute margin of the heart of the right ventricle is gently elevated and held in position by the assistant hand. The distal RCA and proximal segment of its branches is brought in the view. The distal RCA usually palpable, and the epicardium of it can be incised. To provide exposure for the PDA and the posterior lateral, the apex of the heart is elevated toward the right shoulders of the patient. For the circumflex exposure, table can be lowered and left side up, cold lab placed behind the heart near the left atrium, and gently elevate the heart by the assistant right hand. This maneuver will show all the obtuse marginal and the posterior lateral branches of both circ and right coronary arteries. For the distal anastomosis, after the arteriotomy, the vein or the conduit is beveled 30 degrees and slit opening in the heel of the vein, and then start parachuting with the 7/0 or 8/0 proline from outside and in the vein and inside out at the artery. And then after 3 or 4 loops, the vein can be approximated to the coronary artery. And then after at the heel, at the toe, the care must be taken so that if it's not fully exposed, the back wall can be taken by the needle and suturing of it. And because the anastomosis at the toe is important, as it's as that determine the flow to the distal coronary. So a probe can be inserted through the arteriotomy to the distal coronaries to ensure not to take the posterior wall of the coronary artery. After completion of the anastomosis and before tying the vein can be infused with blood cardioplasia through the vein graft to de-air and to check for any leak. Anastomosis of the heel also important, as it's to minimize the possibility of the leak, because any subsequent placement of reinforced sutures in this area is difficult and may compromise the lumen of the anastomosis. Construction of the toe at the anastomosis site can happen when you take a big bite on the artery. So small and close together at the toe prevent narrowing at this site. Sequential anastomosis is to efficiently use the graft and increase the flow in the conduit. The most distal anastomosis should be the largest target vessel, but the downside of the sequential anastomosis is if it's occluded, large area of myocardium is at risk of ischemia. So for sequential anastomosis is done with with the diamond shape. It can be done as a diamond shaped, as it's shown here. So 3 o'clock at 6 o'clock, 3 o'clock in the vein at 6 o'clock, 9 o'clock in the vein at 6 o'clock in the artery. But arteriotomy shouldn't be too long, and which will cause going deformity. Or it can be done parallel, the artery to the vein, to the conduit, with a parachuting technique. Endarterectomy is coronary endarterectomy predated the CABG as a direct surgical approach to relieve the coronary occlusive disease. Recently, there is increased interest in endarterectomy technique because the patient population coming to the CABG has greater atherosclerosis owing to the diabetes, hyperlipidemia, and advanced ages. Most commonly, the need of endarterectomy arises intraoperative when no soft site can be identified for arteriotomy, or the vessel has been inadvertently opened in an extensive disease area not amenable to graft. The perioperative risk of CABG with endarterectomy is higher than with CABG alone in most studies. A retrospective study of 1,478 patients report mortality rate with endarterectomy was 3.2, which was higher than CABG alone. Perioperative MI rate also higher with the endarterectomy group, and the risk of mortality appeared to increase when the multiple vessels require endarterectomy compared to a single vessel. So the RCA is the most commonly vessels that require endarterectomy. So endarterectomy done from should be done from distal to the proximal with a spatula to be introduced between the plaque and the vessel wall. Reconstruction of the coronary artery can be done with the vein patch, and then the usual distal anastomosis can be done to the patch, or prolong the toe of the vein and reconstruct it to cover all the area of the endarterectomy. For proximal anastomosis, it can be done under a single cross clamp, a proximal and distal fashion, or with a multiple partial cross clamp. Before cutting the graft, it should be measured to the length of the with the aorta, with our right heart and pulmonary artery full of blood. This video will show the technique of proximal anastomosis.
Proximal anastomoses of venous grafts are usually done either after the cross clamp is released and all distal anastomoses are constructed, or less commonly using the single clamp technique, which involves constructing a reciprocal proximal anastomosis after a distal one. The completed anastomosis is shown here. Notice how the graft vessel is attached distally to a coronary vessel and proximally to the aorta. If this is being done as a second step, a single period of aortic occlusion and intermittent retrograde perfusion via the coronary sinuses is performed. Notice the positioning of the cranial and caudal ends of the patient, the aortic and venous cannulae, the ascending aorta, and the combined cardioplegia and root vent cannula. The command is given for cardiopulmonary bypass flow to go down. The side biting clamp is applied. The advantage here is that the myocardium can be reperfused while the proximal anastomoses are completed. We can see the ventricle starting to fibrillate. The command is then given for the flow to come back up. The combined cannula is removed with its purse string and its hole is used for proximal anastomosis. We then proceed to prepare the site. Start by dissecting off the adventitial fat overlying the aorta's anterior wall. Then after making a small incision, use a hole punch to make a small 4 to 5 millimeter opening in the ascending aorta. With the site repaired, we prepare the graft for parachuting. The graft vessel should be measured to length and cut back appropriately. The length of the cut should be sufficient to reach the aorta without placing stretch or tension on the conduit, but not so long as to kink and obstruct blood flow. Flatten the graft vessel with a Cooley infant vascular clamp. Expose the heel. Now that we have prepared the graft, we can begin the ligation. We will place 5 loops of 5-0 polypropylene around the heel and through the aortic wall. The stitches should include 3 to 5 millimeters of the aortic wall. Adequate strength.
Yeah, sure.
So you can see in this one, that's the most common utilization, is they start at the heel of the vein. The same for the distal anastomosis. Okay, I shouldn't say that it's wrong to start anywhere else, but in many places where I have seen worked with دبيكي ولا كرافورد ولا هاول ولا هذه الأسماء الرنانة الكبيرة في الكاردياك surgery, we have been taught to do it through the heel first, 3 or 4 sutures, and then you bring it down. Okay, shukran.
Strength of the anastomosis. Make sure to maintain traction on the suture and the vein graft to expose the edge of the aortic opening for accurate needle placement. 2 of these loops will be placed to one side of the apex of the heel. The third precisely through the apex of the heel. And 2 on the opposite side of the apex of the heel. After that, pull on the ends to approximate the graft to the aorta. The heel of the graft should face directly left for a left-sided graft and quarterly for a right-sided graft. Now we complete the anastomosis. Complete by wagon wheel suturing around the aortic opening you've made. The aim of this is to spread the sutures out radially, thus evenly spreading the tension over the aorta. This can be accurately visualized.
Okay, we missed it, but it's okay. What I want you to see is that the way they take the sutures through the vein and through the aorta, and the same also for the coronary artery, the vein and the coronary artery. You should, in the artery, in the aorta or in the coronary artery, you should go from inside the lumen outside, and that will reduce your instance of dissection of the intima or plaque elevation, just in case you are suturing where the plaque is. Okay, thank you.
Thus evenly spreading the tension over the aorta. This can be accurately visualized by observing the edge of the graft vessel and the aortic intima by retracting the graft with forceps and slightly relaxing the suture. Along the lateral edge of the graft vessel, take wide stitches with narrow corresponding stitches on the aorta. This is to ensure the maximal length of the graft vessel is positioned laterally. The direction of the stitch for left-sided grafts is clockwise around the heel and counterclockwise around the aortic opening. For right-sided grafts, this is counterclockwise around the heel and clockwise around the aortic opening. The command is given for the flow to come down and the side biting clamp is released, tying down as the flow is gently increased again. This allows de-airing of the graft before tying down the knot. After the knot is completed, the soft vascular clamp is removed, which allows flow to be established down the graft after the de-airing maneuver is completed. Tying down the anastomosis after removing the side biting clamp allows the knot to be tensioned onto the pressurized aorta in a natural anatomic configuration. The end result should bulge anteriorly above the aortic wall, with a cobra head appearance. The procedure can be summarized in 3 key points. The command for flow to reduce is given before placing or removing the side biting clamp. Just after each, the command is given for flow to increase. In preparing the graft, cut it in such a way as to ultimately keep the flow patent, without tensioning or stretching either the graft or the aorta. Suturing is first done from the inside out for parachuting and outside in for completion. It is important to distribute the radial sutures evenly along the circumference of the opposed graft and aorta in order to evenly distribute tension over the aorta.
So one of the things that can happen is mismatch between the vein graft and the aortic opening. The circumference of the vein graft must be at least 20% larger than the aortic opening. Otherwise, it will stretch out and flat and compromise the lumen of at the site of the anastomosis.
Zainab?
أيوة.
Do you have the consultant with you today?
No.
Okay. Okay. On this picture here, what's wrong exactly? Can you tell me what did I do wrong to have this result?
The size of the vein, I mean the vein is smaller than the opening of the aorta.
So what did I do wrong?
Maybe you open the aorta يعني bigger, يعني you use like 4.8 a punch.
Okay. So that's exactly the answer. So we should always start with a smaller punch, and you can use the smaller punch itself to enlarge the orifice if you need to. يعني فرض these days for you open and it still looks small, you punch that will be very
الدكتور الصوت يقطع. Okay, an alternative to the proximal anastomosis to aorta, a free graft can be anastomosed proximally to the pedicle, internal thoracic or internal mammary artery. This is useful in case of hostile calcified ascending aorta where or when there is a limited length of the conduit is available. So it's the concept of the anastomosis is same as for the distal anastomosis. So you open the arteriotomy is done. Arteriotomy is done with the along the long axis to the internal thoracic artery, and the conduit is beveled, and then as with distal anastomosis, parachuting and continuous suturing of a conduit to the internal thoracic artery should be achieved. The post-operative care, it's post on-pump cardiac cabbage. Hemodynamic support is the main thing should be achieved in the ICU. Early neurological evaluation should be performed to ensure that intraoperative stroke has not occurred. In the hemodynamic stable patient without active bleeding, all attempts should be made for early extubation, and hemodynamic support with a goal-directed weaning of inotropic agent and vasopressor should be carried out early. And chest tube output should be monitored closely for any signs of bleeding. Aspirin to be given within the 6 hours of surgery, and beta blocker is administered if hemodynamically allowed. Glucose control is maintained with insulin infusion until stabilization. Statin should be initiated early in post-operative period in the absence of contraindication. And in case if you use radial conduit, a nitrate or calcium channel blocker may be used to decrease the risk of arterial spasm. Early mobilization should be the goal, with anticipated transfer from the ICU by day 2. Chest tube generally ready to be removed by second or third post-operative day, depend on the output. And diuresis can be initiated by post-operative day 1 and continue until normal fluid balance is achieved. The causes of death after CABG, the most common cause is the heart failure with 65%. Neurological causes is 7.3. Hemorrhage is respiratory failure or dysarrhythmia can happen. The greatest variability in the mortality rate observed across surgeons is attributed to the degree or difference rate of heart failure. Okay. Any questions about the on-pump?
Come back one slide, please.
Mm-hmm.
So what's the incidence of death, mortality of CABG?
It's low. It's around 1% to 3%.
Okay, thank you.
Off-pump CABG. So pre-operative consideration for off-pump CABG, surgeon experience is a must. There is a different set of skill compared to on-pump coronary artery bypass. Better to start with the straightforward cases and advance as gain the experience. There are relative exclusion criteria during the early adoption of off-pump. Recent myocardial infarction, patients have more than 3 graft required, especially multiple lateral wall targets. In case of left ventricle dysfunction, intramyocardial coronary artery, small or diffuse disease coronary arteries, mild to moderate aortic or mitral regurgitation, reduced sternotomy, hemodynamic instability. In case of pulmonary hypertension, urgent cases, difficult lateral wall target or left main coronary artery. All these relative exclusion criteria, because of during manipulation of the heart, hemodynamic instability can occur. So these are the things that increase the hemodynamic instability. Pre-operative assessment is similar to the conventional CABG. Echo is mandatory if there is RV dysfunction, pulmonary hypertension, or valvular regurgitation. Similar as on pump, invasive monitoring is required with the experienced anesthesia team as the key for an off pump is the communication between anesthesia and the surgeons. The median sternotomy to be done, harvesting the vein or can be done open or endoscopic. Epiaortic ultrasound is used for the proximal anastomosis side, and heparin, either a half dose of heparin can be given. Exposure, pericardial traction suture and deep stitch can be used, as seen here. It's a 2/3 between the IVC and the left atrium at the reflection of 2/3 between the IVC and left pulmonary veins at the reflection of left atrium. This will help in traction on during positioning of the heart. Use of cardiac positioner, suction, that is suction based, to maintain the geometry, and coronary stabilizer to minimize the epicardial tension. So this is shows a view from the head of the table, shows the cardiac stabilizer placed away from the apex, and the lateral wall of the heart can be exposed. So this is the stabilizer, and this is the coronary, the starfish and octopus. Here, this view shows the cardiac positioner placed at the apex of the heart, and it can easily displace to view the inferior wall of the vessel, inferior vessel wall. The exposure also can be
Zainab, using this, lifting it up with the apex of the heart. Off pump?
Yes, off pump.
It's amazing that they'll be having ischemic myocardium will maintain hemodynamics in such position.
Yeah.
Okay, thank you.
Have you used it, Zainab?
Sorry, Doctor?
Have you used this? Have you seen it in use?
No.
Any of the other seniors, have you seen it used? Okay, it's very effective, and actually there is a model on pigs that they show how it stabilizes the heart. When you cut the heart totally, the myocardium where you're working on is actually stands still. Very effective for stabilization and positioning of the myocardium. And yes, you have to be worried about elevating the heart, Abdullah, because you may jeopardize the cardiac output. What's the mechanism of jeopardizing the cardiac output at this stage with this kind of position?
Decreasing venous return.
Exactly. So you would choose a nice position that you will still have very good venous return, and therefore you can maintain the cardiac output. And of course, anesthesia have to help you with the lung ventilation in the meantime. Okay, thank you.
Also exposure, the positioning of the operating table is helping in exposing the heart, and use of retractor or tapes, as is shown here, to control the proximal coronaries, is helping with for the the bleeding. Here it shows the LAD grafting. The exposure is obtained by releasing the right pericardial tractions and the lateral traction with the deep sutures, the lateral traction of the deep sutures, and the use of the coronary stabilizer. This also shows a view from the surgeon side, and it shows the inferior, the PDA is stabilized with the retractor or tapes controlling the proximal part. Here, the obtuse marginal is prepared for grafting after positioning of coronary stabilizer and the retractor tapes passed around the proximal coronary artery to allow transient occlusion during the anastomosis.
Zainab, what
Yes.
was that suture, the silastic vessel loop? What is it used for?
To retract and to occlude the vessel for so that not have you will have a bloodless field.
Okay, so there are two different issues here. One, the stabilizer, which is the U-shaped with suction cups, and the other one is the suture that we use to limit the flow in the coronary. Thank you.
The coronary grafting, the anastomosis is the same as conventional CABG. The vessel can be occluded as for preconditioning for 2 to 5 minutes and then release. If patient become hemodynamic unstable, relax the position and Trendelenburg position, give a fluid and inotropes, vasopressor pacing also can be used, or you can place a shunt and release the positioner and stabilizer. Intra-aortic balloon pump also can help for the hemodynamic instability during the hemodynamic instability.
You said something about occlusion of the vessel for 2 to 5 minutes for preconditioning?
Yes.
Have you seen it used?
No.
What other preconditioning are you aware of?
I read about also occlusion of the arm help in.
That's called distal preconditioning, and there's evidence that it will help. But I personally don't use it, and I have not seen anybody around us who use it. Maybe if you look around in Riyadh area or in the kingdom, maybe somebody is using this. But it's though it has been shown to be beneficial in the literature, it did not catch up very well with the clinical practice. Thank you.
This video will show off-pump single vessel coronary artery anastomosis.
This video demonstrates single vessel off-pump coronary artery bypass in a 48-year-old patient who presented with coronary artery disease and unstable angina. Cardiac catheterization performed showed 90% stenosis of the left anterior descending artery with involvement of the ostium. A midline sternotomy extending from the manubrium to the xiphoid process was performed. Dissection was carried down to the skin and subcutaneous tissue until the sternum was identified. Next, an electrical saw was used to open the sternal bone. A roll track retractor is then placed. This is done to harvest the left internal thoracic artery. Pleural attachments to the inner chest wall are taken down, and the left internal mammary artery is then harvested in a form of a pedicle. A sternal retractor is then placed. Pericardium is then incised open. And the heart is dissected free from the pericardium. Pericardial stitches are then placed. The left internal mammary artery is then inspected and is dissected free of the surrounding muscle and fascia in preparation for our single vessel bypass. Papaverine is then injected around the left internal mammary artery. A vacuum stabilizer is then used to stabilize the heart. The left anterior descending artery is then stabilized in its middle pile using the vacuum stabilizer. A beaver blade is then used to make a small incision in the myocardium near the left anterior descending artery. A silastic vessel loop is then passed around the left anterior descending artery and great cardiac vein to allow for proximal control during our creation of the anastomosis between the lemma and LAD. Next, an arteriotomy is then made in the left anterior descending artery in its middle portion. This arteriotomy is extended proximally and distally using Pott's scissors. The LAD is then shunted with a 1.7 millimeter shunt as shown in this video. The left internal mammary artery is then spatulated and a micro-size epidural catheter is then inserted to allow for better visualization during creation of our anastomosis between the lemma and LAD. An end-to-side anastomosis is then constructed between the lemma and LAD using a 8-O-proline suture. We continued our anastomosis. The shunt is then removed, followed by completion of our anastomosis. A Medistem probe is then used to assess for the quality of our single artery vessel bypass. Transient time flow measurements revealed a mean flow of 42 mils per minute, pulsatile index of 1.6, and a diastolic filling of 78%. This concludes our video for a single vessel coronary artery bypass graft.
So the preferred sequence of the grafting is to perform anastomosis to completely occluded or collateralized vessel first. If the LAD is not collateralizing, is not the collateralizing vessel, perform LAD, lemma to LAD anastomosis first to allow for anterior wall perfusion during the lateral and inferior wall positioning. Proximal anastomosis can be performed first to allow for perfusion of the target vessels after each distal anastomosis. This is helpful when doing cardiac positioning, especially if it's not well tolerated. Beware of the large RCA with the moderate proximal stenosis. Acute occlusion can cause bradycardia and hypotension, so prepared with intracardiac shunt and pacing. Patient with moderate MR may not tolerate prolonged cardiac displacement, which can exacerbate the MR and lead to elevated pulmonary artery pressure and subsequent hemodynamic deterioration. So grafting the culprit causing the papillary muscle dysfunction should be performed early in the procedure. The proximal anastomosis can be done with a partial occlusion clamp or as a composite graft to the left internal the internal mammary artery, or using a clampless technique like heart string and PAS port. I'll show you a video of the heart string. So this one, now he just illustrates what is the in this video will show it with intro.
To allow easy control in the event of a mishap. Proximal anastomoses may be performed in a variety of ways, and here one sees the use of the heartstring device for this purpose. The vein is trimmed and the anastomosis is performed in routine fashion. A partial occlusion clamp may also be used, but in these cases we always use epi-aortic ultrasound scanning to ensure that the aorta is completely free of disease. Our preferred technique for some time now has been to use the Cardiac passport device. With the vein mounted in it, it's delivered through the incision and visualization obtained with a 5mm scope placed through a separate port. A right-angled vascular clamp is used to provide counter-traction to avoid any tension on the anastomosis.
Sorry. So a passport is the device used to do a punch and anastomose directly the conduit to the aorta. The outcome of pump the outcome, clinical outcome between the off-pump coronary artery bypass and conventional compared and reported over decade. Even with abundant literature, there is still no consensus for optimal strategies, especially.
Are you showing any slides, Zainab?
كيف دكتور؟
Are you showing any slides?
Yeah. ما في شيء. Sorry. So the passport هنا this one shows the passport device. It's used for to punch the aorta and do or directly the anastomosis of the conduit to the aorta. The outcome, the clinical outcome, have been compared, and over the past decade, several randomized trials have been document the safety and efficacy of off-pump. However, none of these trials showed an in-hospital mortality advantage of off-pump over the conventional. Several registry studies have been published to detect the difference of in mortality's outcome. Retrospective analysis of 42,477 patients from STS national database, and it shows reduction in risk-adjusted operative mortality and morbidity as shown here between off-pump compared to the on-pump. Some other study exists to challenge the STS database conclusion. In one paper that used administrative database of 63,000 patients, there was no difference in hospital mortality between off-pump and conventional CABG. It has been become well recognized that an emergent conversion of a crashed on pump to conventional CABG is associated with significantly higher perioperative morbidity and mortality. In higher risk patients, a more favorable outcome have been reported with off-pump compared to the conventional CABG. اوكي نكمل ولا ناخذ بريك؟
We can have a break for 10 minutes and then we'll come back.
Okay.
Zainab?
أيوة.
You can start.
So now we'll talk about the hybrid coronary revascularization. So and with the hybrid coronary revascularization, we do like surgical revascularization to the LAD coronary artery with the lima through minimal invasive approach, or with PCI to the circ and right coronary artery territories. This shows the comparison between the PCI's CABG, minimal invasive, and hybrid. The potential benefits of hybrid compared to the PCIs, compared to the CABG and minimal invasive CABG, is that to the CABG is the minimal invasiveness and the lower procedural morbidity and mortality, and it's take from CABG like the benefit of long-term patency of arterial graft and lower rate of repeated revascularization. The best candidates for hybrid coronary revascularizations are patients who have a proximal LAD stenosis or CTOs of the LAD, and with it a focal lesion of the RCA or circumflex artery that are amenable to PCI. The patients who have a high syntax score and require a complex PCI are a better candidate to go for conventional CABG.
Zainab, which CTO for the LAD?
Chronic total occlusion of the LAD.
Total occlusion, okay.
A patient who have limited or absence of the venous conduit are a best candidate for the hybrid revascularization, or those who have like severe calcification of the ascending aorta. Also the patients who are high risk to have conventional surgery secondary to the multiple comorbidities, or would not tolerate median sternotomy, especially elderly, disabled, or deconditioned patient with immune suppressed. The contraindication for the hybrid are hemodynamic unstable, patient on cardiogenic shock, or who have malignant arrhythmias, or those patients who are unable to tolerate single lung ventilation due to underlying poor pulmonary function, like in patients with severe COPD with forced expiratory volume 1 less than 50% of the predicted, or who have baseline hypercapnia or hypoxia in the ABG, and those patients who have severe pulmonary hypertension. The procedure can be done as a single stage or double stage or 2 stages. In case of the 2-stage hybrid, you check for the culprit lesion. If the LAD is the culprit, the procedure will be started with the CABG and then followed by the PCI. If the non-LAD are the culprit lesion, then start with the PCI and then followed by the CABG. If it's indeterminate, start with the CABG and then followed with the PCI. The advantage of doing a one-stage approach is immediate completion of the angiography to access the graft, to assess the graft patency, allow for more aggressive PCI, and single operation and single technical fees. The disadvantages the require of operating under potent antiplatelet therapy required for PCI, and requires of a hybrid operating room. The advantage of the two-stage starting with a PCI is allowing for multi-vessel PCI without risk to bypass the graft. Lesion not successfully treated with PCI can be later bypassed, and no need for hybrid operating room. The disadvantage that the CABG must be performed under dual antiplatelet therapy. The PCI is performed without the protection of the Lima to LAD graft.
زينب راح صوتك، ما في صوت.
Zainab?
Hi.
Yeah, she has a connection issue. She's trying to reconnect again.
In the meantime, until she joins, did you manage to arrange for the genre clubs with Haytham?
Yeah, we are working on that. I will contact Haytham and Hussein to arrange for the journal club.
Okay.
الو
ايوه
اوكي طيب من وين فصل؟
السطر الأخير من advantages of two stage.
أي اللي starting with the PCI ولا starting with the CABG؟
أيوة هنا أيوة قبلها واحدة سلايد. أيوة هنا اللي هو number 2 في disadvantages.
طيب so here the disadvantages of starting PCI and followed by CABG, that the CABG must be performed under dual antiplatelet therapy, and the PCI performed without protection of Lima to LAD graft, and completion angiography require an additional contrast load. The two stages started with starting with the cabbage, the advantage that the PCI is performed with the protection of the lima to LAD and allows for evaluation of the lima to LAD graft when doing the PCI, and the cabbages can be done prior to the dual antiplatelets. But the disadvantage is the incomplete revascularization when performing cabbage, and unsuccessful PCI or procedure-related complication will require a higher risk pre-operative cabbage. So the lima harvest can be performed either robotically or thoracoscopically, or directly via small left anterior thoracotomy, and then the lima to LAD anastomosis can be done with the minimal invasive direct coronary artery bypass. So I'll just show you pictures of the mid-cap procedure for lima to LAD. How to perform mid-cap, yes. Sure. No. Okay.
A 73-year-old woman with a history of hypertension is brought to the emergency room with severe chest pain that began 1 hour before. Both in the electrocardiogram as the cardiac enzymes were normal. On TEE, just a mild mitral valve regurgitation was observed. A coronary catheterization is decided. A total occlusion of the descending artery is observed, and a coronary stent placement is not possible by this method. A small anterior thoracotomy is performed in the left fifth intercostal space. A special rib retractor is used to elevate the fifth rib for a better visualization for the left mammary artery harvesting. Just this graft is required, so it's important that this artery is harvested without damage. It's mandatory to mobilize the artery as high as possible to ensure an adequate length to reach the coronary artery without tension. The camera can be useful to reach 5 to 8 more centimeters of the artery. The pericardium is opened. The anterior descending artery is identified. The stabilization device is positioned to expose the descending artery. longitudinal incision is made in the coronary artery and bleeding is controlled with carbon dioxide. The shunt is inserted, and this prevents from bleeding and ischemic problems during the anastomosis. The mammary artery is prepared for bypass. Continuous stitches of 7.0 polypropylene are used to construct an end-to-side anastomosis from the left internal mammary artery to the descending artery. After the shunt is removed, the anastomosis is finished. The bulldog clamp is removed from the internal mammary artery. Thank you for watching this video.
So the results of hybrid procedure. Friedrichs and his colleague reviewed the results of 18 studies in the literatures, which include 367 patients. At 6 months, the Lima stenosis rate was 2% and in-stent restenosis was 12%. 23 patients had an angiogram for recurrent angina, and 1 patient had an occluded Lima bypass. 5 patients will show significant in-stent restenosis with the need of re-intervention. At 1 year, freedom from MACE and angina from MACE was 85% and angina was 75%. There are a large single center series revealed a survival of 92% at 1 year and 84% at 5 years when with the hybrid approach. In 2015, a meta-analysis was published and shows, which include 422 patients going a hybrid procedure, and more than 5,000 patients underwent off-pump, which revealed no difference in hospital mortality of the MACE rate between the two groups. The hybrid approach was associated with significantly lesser length of hospitalization, length of the ICU stay and intubation, and the need of transfusion. This concludes my lectures. Any question?
Come back one slide, please.
Yeah.
So it's unfortunately in this meta-analysis, they did not look at cabbage with pump, because the hybrid and the off-pump main concern is about the long-term patency of the LAD. I think the difference is something like 10 to 15% in difference, while we have very high patency rate, almost 92 to 95% for 20 years in the regular cabbage. It's less in the hybrid and the OPCAP. Anyway, something to keep in mind. But what's your choice? What would you, if one of very close, let's say, relative of yours need a cabbage and he can undergo any of these procedures, which one would you choose?
I think the on pump CABG is the best.
Okay, you have to be able, you have to be able to defend whichever choice you choose, including, of course, the results of that particular center and the surgeon's surgical group in that area. Thank you.
زينب. ممكن بس لما ايش اسمه لما تكلمتي عن الاوكتوبس والستارفش وكذا، بس تعيدين هذه النقطة اللي هو positioning الهارت في الاوف بومب.
So it's positioning different, يعني it's differ when you for which vessel you want to expose. So in case you want to expose the, like here, هنا الstarfish is like positioned away from the apex, and this will expose the lateral wall of the heart. Here it's on the apex, so you can expose the inferior wall of the heart. هنا مثلا to expose the LAD, the octopus is used, and the deep stitch that we talked about is like retracted laterally. They release the right pericardial stitch, so this will give an excellent exposure for the LAD. تمام؟
Okay.
Any other question?
Zainab, thank you for the presentation. Did you encounter any data during preparation regarding the use of flow meter after finishing the bypass? Because it's still not used regularly, at least in our population here. So I'm not sure how effective it is.
Yeah, يعني اللي شفتها, there is some center that use the flow meters. Like, no, I didn't look about what is the outcome when you use the flow meters with after the anastomosis. So I'm not sure يعني exactly what is is there any like benefit added when you use the flow meters.
So you should read about it. Most likely you will find some evidence that it is used. There are other, this is one of the quality measures that they look at, is if you're using post-operative flow measurement. And yes, there is an instance of revision of your anastomosis based on this. So you'll find some abnormal, so you need to know, if you mention this to anybody, let's say in the exam I ask you, how can we find out about the quality of flow in the coronary? Then you say, well, I can do this test, flow meter. Then they will ask you about what's the basis of that? What is it based on? The knowledge behind it, the science behind it. And what are the values that we should accept? What value would prompt you to do something? And what intervention would you do at that moment? There's also another quality measure that I'm not sure if any of you have mentioned it, is doing immediately doing, or on the table, you do, for example, in hybrid labs, you can do an angiogram to look at your anastomosis. And in that, the literature, I think it was published in 2011 in JACC, and it showed that there is an instance of up to 12% of evidence of stenosis, kinking, etc., that require an intervention. So you have to be aware of those quality measures. Yes, I don't think we use it here routinely. Luay, you said you've seen it used here?
Yes, I think one of the surgeons in our institute use it routinely.
And it's a good quality measure. It's good. If you see the surgeon use it, it's mean that he's abiding by the quality issues. By the way, how do you decide, Zainab, how do you decide on the length of the vein?
You mean during harvesting?
So I'm not sure if somebody else, did you say somebody else will talk about harvesting?
Yeah, next week.
So during harvesting is one, and during your anastomosis is another situation.
Yeah,
so in your part here, during surgery, how do you decide on the length of the vein?
Yeah, so I mentioned that if during when you try to measure the right side, and the pulmonary artery should be full of blood so that the length will not be shortened when you cut it. So you need to lower the venous drainage so the heart will be full, and you can measure the distance between the distal anastomosis and the proximal anastomosis with the vein.
Okay, using the same vein, and many times from my experience at least, and the centers that I learned how to do it, is that if you manage to put it at the edge of the, near the edge of the pericardium, on the edge of the pericardium, that will be enough length for you, because remember, the pericardium was on the aorta itself. So if you attach it, and we have a special clamp that we use to attach it to the edge of the pericardium, and that will be enough length. So from experience, but make sure also it's not too long. So you need to tuck it behind the heart, and the whole idea is you should not have any vein or artery or anything crossing the midline, so your redo will not be dangerous. Thank you.
Lu'ay, regarding the flow meter, I've seen that in King Fahd Medical City all the time. They are using this one, post bypass. And then I think it's reassurance other than only quality measures. This is what I've seen. It reassures you. I think it's I'll be more comfortable if I will use it.
So what's the value that you will look at?
What's that, Victor?
What's the value that you would look at? What are you looking at?
There is a diagram will be shown on that monitor to show the flow inside the vein.
So how much is what's the flow rate?
I don't know. I'm not sure.
Once you mention it, you have to know, okay? So sure that you know, and we need to know what it is for the IMA and what it is for the vein grafts as you put it on the coronaries. And how do you what's the exact definition? So do you measure it in what? What's the definition of those measurements? Not only the number, but the definition of also the flow. And what's the indication for you to go back? Let's say you found very little flow. Let's say 10 mils per seconds, or is it whatever? That is very low flow. Usually mils per minute. Sorry. So if you have 10 mils per minute, what are you going to do about it? You're going to just leave it? It will occlude definitely. Anyway, thank you.
Zainab?
Mhm.
Yes. What about the distal anastomosis with large opening or very long opening of the, like, you know, the patch, long opening of the distal target, and also same thing with the vein, like a big that it looks like a patch. Have you came across anything like this?
Actually, for the distal, I didn't I didn't have any. I didn't read about anything, but most important is the proximal one. بس ما أدري الدكتور فريد عنده أي تعليق على الموضوع.
Also, I wonder if the issue with the off-pump or robotic, I don't know if this data also applies to robotic Lima to LED or only the off-pump. And I wonder if the robotic Lima to LED will improve the patency of the graft compared to the standard cabbage, which is the on-pump.
The robotic Lima to LAD is considered as one of the approach for the hybrid. So hybrid can be done as a minimal invasive with a mid-cap incision, or can be done with the robotic harvesting of the Lima, or endoscopic harvesting of the Lima.
I understand, but was the robotic one of the options that were studied in this study you reported? And this was my question.
Okay.
If it makes difference other compared to the other, because I mean, like with robotics, I believe the visualization is excellent, and I wonder if the technical issue will be technicality will be an issue.
Mm-hmm. This studies that I read, they didn't mention what is exactly the approach. Did they use like a med-cap, or is it like endoscopic or robotic? They just mentioned it's a hybrid approach. Then robotics, you harvest, you do the anastomosis as a mid-cap. You harvest the Lima as robotically.
Yeah, you're right.
طيب. Any other questions?
You have scenario زينب ولا؟
لا ما في نفتح تسرع.
Yeah, I think since we have some time, we can pick a case from Tisra and discuss about.
نحتاج ايش؟ تبي 5 minutes break؟
Yeah. يعني for
ايوه خذوا صحصحوا عشان تجاوبوا مو بس قاعد اقرا.
Okay, so we'll start at 3 p.m.
Okay.
زينب
Mhm.
جاهزة؟
Yeah. واضحة سكرين؟
Yes.
Yes.
طيب. Okay. So this chapter of from TESRA will cover stable angina, the concept indication of CABG, pre-operative evaluation, the conduit selection and consideration, operative management, the potential complication and alternative management strategies. So the chief a consult on a 72 years old man with a history of exertional chest pain following a highly positive exercise treadmill test in the community. He was referred for a coronary angiography. This revealed 3 vessels disease with moderate depressed LV function. So ايش بتسوي؟
And you first should take full history from the patient and know what's going on.
Mm-hmm.
You should know the story, the whole story, and not only this one.
Mm-hmm.
And you examine, of course. And then later on you decide about the risk of the surgery, and then you take him for surgery.
Okay, so you just history and physical examination. You will not do anything else. So
investigation also. Now they said that they did treadmills, huh?
Okay.
And then of course I would do the ECG and the chest X-ray with the routine labs.
Mm-hmm.
And the cardiac enzymes, of course.
طيب هنا يقول لك okay.
For this patient, I will first make sure that he is on like on the highest level of medical therapy. Like he used all of his options regarding medical therapy before thinking about invasive revascularization, because he's now complaining of he's an unstable angina. So first we will make sure that he undergoes trial of medical therapy first.
Okay. So بس first الحين أنا قاعدة أسأل عن the pre-operative assessment before treatment.
We for him surgery then.
طيب. For depressed LV function, anything to be done with 3 vessels? Will echo satisfying? No, they are saying just moderately depressed LV function.
Maybe I need to do first echo for him to confirm how bad is the LV function and if there is any regionality.
Mm-hmm.
As a pre-op, if he has any valvular function,
okay,
any valvular disease,
mm-hmm.
I might think about he might need another like valvular repair with the cabbage or replacement. But for the LV function, to know the regions, if the myocardium is viable or not, if he will benefit from revascularization for these areas.
Okay, so what you will do is to look for the viability of the
First, I will see the diseased vessels and compare them to the motion abnormality on the LV myocardium.
Mm-hmm.
Like if he had kinetic anterior wall and he has like a distal LAD or mid LAD disease, maybe that area is infarcted already and he might not benefit from revascularization of that vessel. For example.
ممتاز. Okay. طيب. So we talked about the history and the physical examination, and then the test, the lab, routine labs, and ECG, chest X-ray, and the angiography, echo for the assessment of the ventricle size and function, and rule out any other past valvular diseases or aortic disease. The viability study used in patients with multivessels with the low ejection fraction or extensive area of akinesia to ensure that the bypass is to a viable and salvageable myocardium. Especially, this is helpful, especially in high risk. There is any questions about the utility of the scan. Is the most commonly used method. MRI also can be used.
زينب, the non-viable non-viable myocardium, if you revascularize, مو بس not beneficial, it's fatal also, صح?
I think last week we discussed this about the revascularization of non-viable myocardium, صح?
Yeah, I don't know. I don't remember.
So in this case, it looks like the patient have clinical evidence of ischemia. Angiography was done and echo showing moderate, some impairment, not terribly bad, impairment of the LV and 3-vessel disease. So to me, viability is really not indicated in this patient. I personally would consider doing viability in a very low ejection fraction, and even that you have to look at the current literature which says that there is no benefit, no extra added benefit of doing any viability studies. Either you do the procedure or you don't. But I would personally still think that viability will help me decide if I should operate on those patients or not. In this particular one, the ejection fraction was not bad. I mean, so why would you do? Was it indicated here that you should do a viability study?
No, this is the pre-operative assessment and what are the options that is available for patients.
Would you do if you have an ejection fraction, let's say of 40-45%, would you do a viability study?
What I know from حتى في الكلينيكال هذه إنه they do the viability studies when there is like akinesia or with the severe LV dysfunction.
It has to be significant akinesia that you're worried about doing an extra bypass to an area which is not indicated, or the patient is very sick that he may not come off bypass. So you have to be a little bit in many patients with reasonable ejection fraction. And I'm talking about anybody that 40 or even 35% and more. You don't really have to do a viability study unless you have something else to tell you. For example, there was an Italian study, I think it was just about 10 years back or 8 years back, and it shows that echocardiography was able to differentiate scar tissue in different areas where you have abnormal wall motion abnormalities. By the way, I've never heard, I shouldn't say that, but the term of regionality is kind of original to me, but anyway. So it's regional wall abnormality. And if you have a regional wall abnormality, it's with dyskinesia and thinning of the wall with brightness on the echo, that all indicates scar tissue, and that area probably will not benefit from bypass. So it may help you decide on how many bypasses, which vessels would you decide to go to.
But Doctor, he stated here that myocardial viability used in patients with multivessel disease, low EF, less than 50%, or extensive areas of akinesis.
Yeah, so it has to be, sorry, did you say 15% or 50%?
50, as
Okay,
he mentioned here.
This is probably not applicable, especially with the current literature. I think there was a recent publication with the SHOCK 2 trial, and basically they say there's no benefit of viability studies. You need to review that. It was in the last 2 years or so. I'm not really keeping up with that, but I'm pretty much sure that this statement of less than 50 does not apply. Have you seen it done here, Loy?
No, we don't do it. Yani, patient is with moderate ejection fraction. We usually proceed without viability.
And most of the people everywhere who do quite a few of CABGs, maybe 300, 400, 500 cases in a year, they will not do viability study unless you reach that level of concern, which is low ejection fraction. At one time, and I still believe less than 30 is significant. And if you have somebody presenting with heart failure symptoms, and if you have a scar tissue on the echo.
Okay.
Continue, please.
The conduit studies like venous mapping may be used to assess the suitability of the venous vein for bypass. The mammary can be assessed by either chest duplex or direct injection during the angiogram. So,
by the way, that's a recommendation in the guidelines, mapping of the venous of the greater saphenous vein, which we don't use in our hospital, but I think 2 years back, there was a study that Faisal Fallata have brought to our attention, and accordingly, we, at least from the resident point of view, I suggested that they should bring this to the attention of other attendings. I did not use, and I believe it's a good technique to use. It can save you from when you get the vein out to avoid making a big flap and necrotic tissues on the leg wound.
Dr. Farid, do you think it has to be done for all patients or specific patients?
It's a quality issue and it's recommended for all patients.
Okay.
I found that the location of the vein is not the big issue from what I've seen, rather than the quality of the vein. And I believe the venous venous mapping you can assess the size and the quality. I know one center they do for all patients regularly, also for the radial.
So additional information, this patient is a type 2 diabetes on oral agents with hypertension, dyslipidemia, and remote smoking history. There is a 6-month history of retrosternal chest pain and dyspnea on exertion, New York Heart Association 2, which has worsened in the last month. prompting a visit to his primary care provider. Angiography revealed severe 3-vessel disease with a high-grade proximal left anterior descending and circumflex stenosis, left main equivalent, and high-grade mid-distal RCA stenosis. Echo demonstrate hypokinetic anterior lateral wall segment with the resting left ventricle ejection fraction of 40. His EKG is negative for ST elevation and cardiac markers are negative. So Faisal.
Yes.
Yeah, so now what is your treatment strategy?
For this patient?
Mm-hmm.
So he's a type 2 diabetic with reduced LV function and 3-vessel disease. So if I remember correctly, it's class 1 for him, cabbage. But it would be, it will be for survival benefit also, not only for the symptoms he's having.
And is it like the first choice, or is it like you have?
Is it what?
Is it your first choice? يعني هنا they didn't mention, هنا they didn't mention about the medical therapy.
There is, I say, there is 2 points. First, did he is he now on maximum medical therapy? And the second point is his risk score. We did not calculate that before deciding for the surgery. How is he? Is he high risk or low risk? But it seems from this follow-up, he doesn't have any other comorbidities. And I assume, since they did not mention, that he is a functional man, not frail. So cabbage would be my first choice for this patient.
What is your definition of maximum medical therapy? يعني what are the medications that is the patient should be on before يعني?
Patient with stable coronary artery disease needs to be on statin therapy. He needs to be on beta blocker, and since doesn't need to be on beta blocker, he needs to be on aspirin. He needs to be also on ACE inhibitor, especially if he's hypertensive and diabetic and with reduced ejection fraction. Maybe if he is dyslipidemic with high LDL, maybe he needs another medication for his dyslipidemia. That's what I think maximum medical therapy means. He doesn't need to be in dual antiplatelets because he did not have a stent. He doesn't need to be on beta blocker because he did not have an MI, an ACS. I think that's it. Did I forget something?
ممتاز. So, as Faisal said, he needs to be the guideline for stable chronic stable angina. For non-pharmacological measures need to be smoking cessation, limitation of alcohol, regular physical activity, and modification of the diet and weight loss. For the pharmacological measures to reduce the symptoms and to prevent myocardial infarctions and death, aspirin, beta blocker, statin are routinely used in a stable angina patient who are capable of tolerating them. Angiotensin is indicated for diabetic and patient with LV systolic dysfunction. So revascularization depend on the guideline. In this case, he's left main equivalent with diabetics, and it's the cabbage is class 1 for to improve survival.
So Zainab, let's say you started this patient on maximum medical treatment, and yes, his angina has disappeared. But we know now that he has LV dysfunction, moderate, and he has 3-vessel disease. Which way would you go?
After maximum medical therapy, he improved?
He improved in a sense. He has no more angina on medical treatment, on full medical treatment. But we know that he has 3-vessel disease and moderately impaired LV.
I would follow him. If there is like close follow-up, if there is any development of the symptoms, I think he's considered for like cabbage.
Even if he doesn't have any more angina, صح?
With the follow-up, if he develop, if he develop any symptoms of
No symptoms. He has no symptoms. He only we know he has 3-vessel disease, and you can calculate the score there. Let's say from the Syntax score, and then he has also LV dysfunction of let's say 40% or 38%.
With follow-up, you do an echo, so the ejection fraction should be improved.
Going with treatment, and right? What do you think, Faisal?
I think even if the angina was relieved by the medication, we're doing it for survival benefit. He has left main equivalent. I would speak with the patient and tell him that he will need the cabbage, because the next time we might not catch him when he has an MI.
Not necessary. He will have further problems, and he may have further, but we know that his mortality is better if he undergo coronary artery bypass. So Zainab, yes, you can start all patients on some sort of therapy, and you can delay the surgery for a limited period of time, a few weeks usually. But with this kind of scenario, maybe it's better for the patient, according to the guidelines, that there will be some survival benefits for those patients. Okay, thank you.
طيب. Anybody wants to talk about the operative step for the cabbage? ولا اختار أنا؟
It's always better if you choose. Not here only, but for the whole life.
يعني ما في volunteer.
عبد الله الحديب موجود.
عبد الله ودك تقول؟
No, I prefer Loy actually.
أنا شايف ناس ما شاء الله عمالقة في الموضوع. شو اسمها دي دكتورة حقت الجامعي، من هي؟ هنوف موجودة؟ Yeah, she's there. You can ask her. Maybe she's. I'm not sure. What was your question?
Operative steps of cabbage. تو شرحتها يا ناس.
طيب زينب, let me try. So we'll start by we planned already our incision. So we'll start with the skin incision. We'll use the scalpel, and then we'll dissect with the cautery. We will do our hemostasis. We'll control any bleeding, and then when we reach the sternum, we will mark the area that we will use the saw with, and then we'll open the sternum with the saw. We will then do our Pericardial, and we'll put some stay sutures to hold the pericardium. Then we will plan our cannulation and the cross clamping. We will start with the aorta. We'll do our cannulation, and then the right atrium. That might be the single cannula, right?
Okay, you'll do single cannula. هنا ليش؟
We are doing cabbage, يعني no valves, nothing.
Okay, تمام. طيب
Yes.
بعدين.
And then we will we will connect, يعني we will divide the lines and connect to the pump.
Mm-hmm.
And then we will apply.
You divide the line after you cannulate, ولا you cannulate then you divide the line?
لا شلون we cannulate
and then
لا احنا we already divided the lines and then يعني we are ready to put them on.
Okay, طيب.
Yeah. And then we are on pump. Okay, we will apply our cross clamp and we will deliver our cardioplegia.
Mm-hmm.
And then regarding the so our saphenous vein is already there. We will do the distal and then the proximal anastomosis.
متى تسوين الليمة هاربر؟
From the beginning, sorry. We have to do the lima from the beginning.
Mm-hmm.
Before the pericardiotomy.
تمام.
Yes. And then we'll clamp it, we'll leave it there. We will do the pericardiotomy, we'll do the stay sutures, and we'll proceed.
في أحد ثاني؟
But what type of cardioplegia will you use, يا آيات?
I'm not sure.
You can tell us, Faisal, what type of cardioplegia you'll use.
I will use blood cardioplegia because it has the potential of being more myocardial protective, and also it will help me with the anastomosis to check for leaks because it will be more visible.
Yeah, it makes sense.
طيب.
Hello?
أيوة.
Yes, so let's start from the early beginning for this case, like after shifting the patient to the OR.
Mm-hmm.
I'll ask the anesthesia to insert 2A line, and after the induction of the anesthesia, he will insert the TEE and give me an early images for the valves and LV function. Then I'll ask him to insert central line, and we'll considering femoral line in such a patient. Then after induction the anesthesia, we'll insert a Foley cath for sure. Then we'll start my incision, sternotomy. After the incision, we'll start the sternotomy, and then we'll harvest the lima, and I'll ask the resident or the assistant to start to harvest the saphenous vein.
Mm-hmm.
Then after harvesting the lima, before I started to incise the lima, I asked to give heparin.
Mm-hmm.
And after giving the heparin, we'll start to cutting through the pericardium. And after cutting through the pericardium, we'll start the cannulation. So the line should be divided before the cannulation by the resident or by the assistant there. We'll start the cannulation, and after that, we'll give the cardioplegia. And as Dr. Faisal said, the blood cardioplegia is better in this case, antegrade cardioplegia. Then first we'll start to do the anastomosis, the vein anastomosis. Then the last we'll do the lima to LED, 2 vein, 1 to the RCA and the other to LCX. Although I prefer to use RIMA in this case. Then I'll use after finishing all the anastomosis, I'll use the flowmetry to make sure that my anastomosis is going well. Then خلاص, we'll finish with the case. And before that, I'll ask the anesthesia to do a TEE, a second TEE, to make sure that everything's going well.
طيب دكتور عبد الرحمن.
هلا.
You said you will use the REMA, but this patient is old and diabetic.
Yeah. صح. The patient is diabetic, so yeah. In some cases, I'll use pedicle lima and skeletonized REMA to reduce the risk of infection. But yeah, I don't know. I prefer to use the bilateral mammary, pedicle lima and skeletonized REMA. Yeah, this is a brief.
Do you have any evidence of that using one skeletonized and one pedicle?
Yes, yeah. We're having evidence that it's reduced risk of infection in diabetic patients.
What's that evidence?
والله it's مش يعني ما متذكرها حاليا بس I remember that
the one I'm aware of, if you use bilateral skeletonized versus bilateral pedicle. I'm not sure if any have proven that you can alternate by using one pedicle and one skeletonized. If you mention this, you have to be aware of the evidence, because I'm sure somebody will be asking this question.
Yeah,
it's well known, evidence-wise, it's well known that bilateral skeletonized is better than bilateral pedicle. But even bilateral skeletonized will still have higher infection rate than unilateral pedicle or skeletonized IMA. By the way, in the film that you showed, Zainab, they look like they got the pedicle lima and then they skeletonized it when it's out.
Yeah.
Which is
I've noticed that.
Defies the main aim of skeletonization, which is surviving of the sternal edges. Now, you can do that if you're stuck with a problem after you harvest the lima as pedicle. What would be your indication to skeletonize it after you get it out, Zainab?
الدكتور حقت الميد كاب.
It doesn't matter. Any case, you got the lima pedicled. Sometimes you may have to skeletonize it after you have got it out. What would be that? What would be the reason for skeletonizing the lima after harvesting a pedicle?
Sometimes the branches of when we do the pedicle harvesting for the lima, sometimes we're having a big branches, so it will bleed there. So I remember one case, we harvesting a pedicle lima, then we couldn't control the bleeding. There was a lot of bleeding. So the surgeon, he bought a bulldog and started to skeletonize the lima, so he had a better view for the branches. I think this is one of the indicators.
That's more like branch control rather than skeletonization. When we talk about skeletonized lima, we're actually making sure that the whole length of the lima is completely freed from the rest of the structures, surrounding structures, being the vein or the muscle or the fascia. So,
if the flow was
semi-skeletonized.
If the flow was inadequate or suboptimal, and you want to inspect the rest of the lima for any lesions or
you can inspect it without skeletonizing.
Or you find any tissue that compressing you remove all the areolar tissue to and try to remove any restricting.
The areolar tissue does not compress, and if you in your examination of the lima you find a hematoma or something, you can explore that area, like Dr. Roueli have mentioned. But the reason, the main...
If it was short, maybe.
Say that again, Faisal, I didn't hear you.
If we need more length, if the pedicle was short, we skeletonize to more length.
That's the only reason. I shouldn't say the only reason. That will be the main reason to skeletonize the lemma after you harvest it. You try to put it in the proper spot where you have dissected the LAD and it doesn't reach, or it reaches with some tension. So skeletonizing may help in that regard. And yes, it will be bigger, it will be longer, and you can gain up to 4 centimeters by doing so. Some of your patients may have an early bifurcation of the lemma. That can also lead to shorter lemma, and you may have to resort to skeletonization. But Dr. Roueli, if you are going to skeletonize the vessels, the lemma, it should be done at the time of harvest. So you would have, you would preserve the other blood supply and the venous drainage of the sternum. Thank you.
دكتور فريد.
Okay, تفضل عبد الرحمن.
Can I ask you a question? Do you prefer to clamp the pouches or just diathermy?
It very much depends on the size. Many times you can go very fast with the diathermy, but occasionally you'll find a vessel that's reasonable enough to clip. So when I look at my grafts and the x-ray afterward, I would find maybe, I would say 10-15 clips on the lemma. Sometimes some people may use excessive use of the clips, that you'll use 1 or 2 cartridges. I usually don't do that. I don't complete 1 cartridge in 1 lemma, but that doesn't mean that I'm doing the perfect number. No, I think I've seen surgeons who never use any clips, and they can finish the lemma in 10-15 minutes. They are already done with the lemma. So. And they have no problems with their patients, not bleeding, no disasters afterward. I guess it depends on the level of confidence of what you do as a surgeon. So I'm somewhere in the middle between this and that.
So it depends on the situation.
I don't do any more lemmas for the last, maybe 15, 20 years. I haven't done any lemma.
Thank you.
Guys, do we usually put a TEE for CABG patients for post-op evaluation, or it's not that much necessary, like the valve surgery?
Well, actually, I think the anesthesia, they already had the TEE there. So just to make sure that I'll ask them to reevaluate the valves and the LV function. So it's already there. Why not?
Yeah, but I already assessed my patient before. I mean, just for post-op, after the surgery itself. For the echo, I know already.
The patient. You mean after shifting the patient out of the theater?
No. I mean inserting the TEE intra-op.
Okay.
Is it? Yeah, before the surgery. And when patient on table, already intubated, anesthetized, sedated, we insert the TEE. Usually we have problem inserting the TEE. So is it necessary, like the valve surgery? Because for the valves, of course, we need the TEE for the function, but for the CABG,
the TEE.
I don't know what kind of a problem we're facing.
TEE is not only, I think, for, I'm sure it's not for valve only evaluation. Yes, it can help you assess the volume status, the myocardial wall function, contractility, in case you have problem with one of your anastomosis. It is helpful. I mean, one of the anesthetists said once that if I have a TEE, I won't need Swan-Ganz catheter to measure the PA pressure, because I will see the RV dilated, for example. See, so it's not only the valve.
The TEE, it's going to be there the whole time. What I know,
and what I've seen that the TE, it's going to be there the whole time of the operation. So no need to take it out and insert it again.
What do
I
you
know.
think?
I mean, from
Yeah.
the beginning, sometimes the
Okay.
anesthesia will struggle, or somebody that inserting the TE will struggle inserting
Okay.
it, and will be having bleeding and so on. That's why we don't, yeah, sometimes.
What do you think, Roy?
Yeah, I asked one of the cardiologists before regarding this issue, and it's controversial. Some centers do it routinely. In our centers, we don't do routine TE for like straightforward cabbages. I believe that it's not necessary for straightforward cabbages.
This is what I'm saying. This is what I mean, Loay.
So until now, there's no specific guidelines that would recommend using it, even from anesthesia point of view, though anesthesia is gaining grounds with echo, and if they are expert, they would like to have the echo on board. In cases like this one, for example, if this patient have impaired LV, it may not be a bad idea. But we also are different in our institute. For example, we don't use routine TE. We don't use Swangans. Almost rarely we do that, and occasionally for transplant maybe. So it's very unusual to use those, though some other places routinely use Swangans, for example. So those variation, if you decided to go with one way or another, you should always have a solid ground to explain why you're taking this extra step. Just like I had said, there is some morbidity associated with that, but with more professional help and expertise, the number of complication is very much reduced. Also, there's cost associated with that. But of course, if you go somewhere and somebody have to pay for this, everybody is willing to take the extra time and money maybe for it. Anyway, thank you.
Okay. So for the operative steps, we mentioned general anesthesia with endotracheal tube, invasive arterial, central venous access, swung catheter. Just now mentioned that it's not like routinely used. It's reasonable to routinely use transesophageal echo for pre and post cardiac assessment. Standard skin preparation, draping of the chest with the groin and both leg exposed, arm prepped and draped if the radial artery harvest is necessary. Median sternotomy, harvest the lima and then with the and harvest of the other conduit. Administration of heparin with a goal ACT of greater than 480. And verse T pericardiotomy. Pericardial stay, palpation of the aorta, cannulation, right atrial cannulation, aortic cannulation, right atrial cannulation with a two-stage venous cannula, root cannulation of antegrade cardioplegia and aortic vent, plus minus retrograde via coronary sinus. And we mentioned what are the indication for a retrograde retrograde cardioplegia. Initiation of bypass when the target ACT achieved, cross clamp with antegrade cardioplegia arrest, consider retrograde as well if severe proximal disease, intermittent maintenance dose of antegrade or retrograde through cross clamp period after augmented with cardioplegia down the vein graft. Final preparation and review of conduits, identification of the epicardial targets, assessment of the quality and feasibility of the grafts, begin with the distal right, DR and size the graft to the proximal aorta with the heart engorged, hook up a cardioplegia line to the graft if desired. move into the SARC, then LAD. The order may be institutional specific. Performance of distal and proximal anastomosis and pay attention to the anastomotic quality, lie of conduit and adequacy of territorial perfusion with the new graft. For proximal use, running proline, full thickness bite on the aorta, de-air after the last proximal, and then remove cross clamp and reperfuse. Placement of epicardial pacing wire and chest drain, weaning of bypass, decannulate, administer protamine, 1 milligram to half milligram protamine to heparin, or 1:1. Aiming to normalize the ACT, assessment of the operative sites for hemostasis, chest closure, and transfer to the IC. تمام؟
How do you de-air the coronary grafts يا زينب؟
في البروكسيمال انستوموسيس bulldog على الفين graft, and after the last anastomosis, I mean before tying, you release the cross clamp to de-air it, and then tie the anastomosis.
So if you have air in the graft, the distal part of the vein, having loose sutures and filling the ascending aorta with blood is not really going to help, because it will push the air bubble toward the bulldog, right?
If the distal anastomosis is loose,
no, you're doing now. You've done with the distal. You're doing the proximal on the aorta, right? Is that what you meant by the last sutures?
Yes.
Okay, so you have a bulldog now in the vein, and you have an air column in the on the distal part, or sorry, in the proximal part of the vein. Now you try to de-air it by the mechanism you mentioned, by filling the ascending aorta, okay, and tying the last sutures, but the air column in the vein will not go anywhere, right?
Yes.
So what are you going to do about it?
ممكن كمان we can use like needle or
yeah. What kind of
في ناس يستخدموا النيدل تبع السوتشر وتسوي دي ايرنج، وفي يستخدموا تبع الانستموسيس. سوري دكتور.
أسمع صوتك دكتور فريد، يقطع الصوت.
I'm sorry, I didn't hear you. I was disconnected.
دكتور ايش سؤالك؟ لأنه كان صوتك يقطع ما سمعتش.
Okay, ما سمعتش. I was asking about how do you de-air the coronaries, and if you have seen it in the OR.
Yeah, so في OR they use like في two type. في ناس يستخدموا النيدل تبع الانستموسز ال 6 O's اللي they anastomose with it, و they de-air after, يعني if there is an air in the proximal part of the vein. And some use like the needle, like the peripheral PIV needles to de-air, the small size.
What size of needle is that?
ممكن كانت 22 أو 24 شيء زي كذا.
22 will get you in trouble. Usually we use 25. It's called it's a TB syringe. Anyway, Luay, have you seen any other technique of de-airing?
No, the one that Zainab mentioned only with using the needle. That's the one I saw.
Which needle?
The needle of the suture itself. After cutting the needle, they use it to make some holes in the vein.
Okay, and most of the time you can get most of the air, but occasionally you have to use suction, and that's why I use personally the TB needle. It doesn't have to be. All right, thank you.
طيب. That's it.
يعطيك العافية زينب، شكرا جزيلا.
يعطيك العافية زينب, nice presentation.
يعطيك العافية.
See you next week, inshallah.